Good morning. I'm Demir Bajin. I'm one of the audiologists at Western University, London, Ontario, in Canada. And my audiology counterpart is Ranjith Rajeswaran from Chennai, India. Our topic is ear malformation. So I'll be based my talk on the malformation system that was published back in 2017. And this is a diagram showing all the malformations, but today I'll be focusing on cochlear hypoplasia, because of it's the interesting presentation of the different types of hearing losses. The definition is the external dimensions of the cochlea is smaller than a normal cochlea. It represents about 12% of the malformation group, and it can come with any type of hearing loss, from mild sensorineural all the way to profound and mixed, and sometimes just pure conductive. In cochlear hypoplasia cases, you can have a hypoplastic or aplastic aperture, as well as you may not see a cochlear nerve. And in some types, you can see facial nerve anomalies, which can due to associated semicircular canal abnormalities. So you can see the different four types here. Type 1 and type 2 are more severe. They're smaller cochleas, and then type 3 and type 4 are more developed cochleas. Just to go back, and type 1 is just a small bud, and usually associated with cochlear nerve aplasia and hypoplasia. Type 2 looks like a smaller form of incomplete partition type 1, a cystic cochlea, and type 3 is also known as 1.5 turn cochlea. And type 4 is very interesting, is a fully developed basal turn and a shrinked mid and apical turns. And in type 3 and type 4, they're more developed, so you tend to get almost close to normal hearing, only sometimes just a mild sensorineural, which can benefit from hearing aid. And they can also present with conductive hearing loss or mixed hearing loss due to stay-piece fixation, and they can benefit from a stapedotomy and hearing aid. All of them can also present with profound hearing loss, and they're candidates for CI and ABI. And here you can see a diagram showing all the possible outcomes for cochlear hypoplasia. They can present with mild, moderate sensorineural hearing loss, which can benefit just from hearing aid. You can see conductive, especially for type 3 and 4. You can do a stapedotomy, just a hearing aid, or because the facial nerve anomalies can complicate the surgery, you can directly go to bone-anchored hearing aids too. They can also present with mixed hearing loss, then you can do a stapedotomy, and then they benefit more from a hearing aid. Or they can present with severe to profound sensorineural hearing loss, and depending on the cochlear nerve on the MRI, you can either go a CI with a thin and short electrode, or if there's no cochlear nerve, you can directly go to ABI. And in the cases where you have a cochlear nerve hypoplasia, you can aim for a bimodal stimulation depending on which side has a better or more robust cochlear nerve. You can do CI and ABI either sequentially or simultaneously. So we have a case to present. This is actually a case that was referred to us after the Niagara meeting from Alberta, a 10-month-old kid with a right cochlear hypoplasia type 2 and a left common cavity with a robust cochlear vestibular nerve. And on the audiological testing, there was some ABR response on the right, but there was no response on the left. And looking at the CT scan, you can see the cochlear hypoplasia type 2 on the right side, and a common cavity on the left. And looking at the MRI, you can see a tiny nerve on the right, and a robust cochlear verb, like a thick cochlear vestibular nerve on the left. And on the sagittal oblique cuts, you can see that tiny cochlear nerve on the right and a large-sized cochlear vestibular nerve on the left. So from now on, I would like to hand over to my audiology partner here.
Well, so from the audiology perspective, the question is in terms of decision making and management. So do we have to go for a cochlear implant or a brainstem implant? On the right side, where you have a common cavity, and on the left, he said, with the previous case, you have a normal ABR. So now the most important thing is, especially when you have to make a decision, when you have a bilateral common cavity, and if you have to make a unilateral implant in this case, or a case where you have to have a cochlear implant on one side or ABI. So decision making between a cochlear implant and ABI is very, very critical in these cases. So one of the investigations that we add, apart from the regular clinical testing, is electric ABR. The advantage of electric ABR is even if you have a profound hearing loss where conventional acoustic ABR fails to measure the nerve responses due to lack of transduction process, you can directly give an electrical stimulation to measure it. So this has been part of our clinical routine in this gray zone candidates. Electric ABR is nothing but instead of giving an acoustic, giving electric, and you can also do it pre-operatively, and this is what we call it as a trans-tympanic or premonitory ABR. Now, in this case, we place an electrode right on the promontory. So initially, there was a lot of discussions whether is it possible to place the electrode when you don't have a round window niche in case of a common cavity, but it was not a problem anymore for us. So you can just place it on the promontory and you can stimulate them. And there are two types of trans-tympanic EABR depending on the type of the electrode used. One is a golf club electrode, which you can place it on the round window niche and give an electrical stimulus, or on the promontory and give an electrical stimulus. Or you can also use intracochlear electrode, which is a ANTS electrode, which is developed by Middle, with three basic electrode contacts where you can open the round window, the round window, you can push an electrode inside and can give a stimulation. The difference between the trans-tympanic and intracochlear electrode is the morphology of the EABR when you do intracochlear stimulation is much better because it stimulates more spiral ganglion cells, and you have 4 electrodes. When you stimulate it using a single electrode or a golf club electrode on the round window or a promontory, the spread of current is very minimal and it cannot stimulate more spiral ganglion cells. There will be a difference in terms of morphology. However, definitely ABR could be recorded. And as you know, this is a patient with a common cavity. This is one of our recordings in patients with common cavity. The hallmark of ABR is replicability and amplitude growth function, and the latency intensity function. As you increase the stimulation level, the latency of the peak is reducing and the amplitude of the peak is increasing, and more peaks are emerging as well. So we would like to highlight trans-tympanic EABR has been very useful in decision making in this critical cases. And this is our protocol, a patient with anomalous cochlea, anomalous nerve. So it's the most important thing that we add is the trans-tympanic EABR. And of course, the trans-tympanic EABR is done in GA. If the patient is fit enough to undergo GA, then we do a trans-tympanic EABR. Depending on the responses, we would decide to go for a cochlear implant or a brainstem implant. So going for a CI or ABI is a collective decision, and the most important person who takes the call here is the patient. So for example, if you have a patient where the trans-tympanic EABR morphology is not very convincing, then we would again discuss with the team and the patient. If the patient prefers to go for a brainstem implant directly, then we go. Otherwise, if you have an implantable cochlea, the first step is always to do a cochlear implant, and based on the performance, we'll switch over them to brainstem implant.
Thank you, Ranjith.
Thank you.